Blistering disorders. Letter of referral. Dear Doctor. Mr. Ralph Spencer, aged 75 years. This retired man presents with a 6-week history of an itchy eruption on his torso and limbs. Over the last week, he has developed blisters. I suspect he has developed pemphigus vulgaris and I would be grateful if you would see him urgently. Yours sincerely. Introduction. It is always worth checking carefully what the patient, and even nursing or medical colleagues, means by blisters. Sometimes it is quite different to what you expect. In an elderly patient with a widespread, itchy, and blistering disease, bullous pemphigoid is the most likely diagnosis, but a careful history and examination will narrow down the diagnostic possibilities. Skin disorders presenting with blisters or erosions. Immunobullous disorders. Bullous pemphigoid and pemphigoid gestationis. Pemphigus vulgaris. Dermatitis herpetiformis. Mucous membrane pemphigoid. Infections. Herpes simplex. Varicella zoster, chickenpox. Herpes zoster, shingles. Bullous impetigo. Cellulitis, occasionally blisters, if severe. Reactive. Bullous erythema multiforme. Toxic epidermal acrolysis. Staphylococcal scalded skin syndrome. Bullous drug eruption. Bullous insect bites. Acute contact dermatitis, in florid cases. Miscellaneous. Porphyrias, cutanea tarda is most likely. Pompholyx, dyshydrotic eczema. Diabetic bully. Your immediate priority is to recognize and treat diseases that may become life-threatening, in particular toxic epidermal acrolysis, 10, pemphigus vulgaris, eczema herpeticum and varicella zoster in the immunosuppressed. NB. Widespread erosion of the skin as a result of blistering is potentially life-threatening due to the consequences of fluid, electrolyte and protein loss and, in particular, secondary infection causing septicemia. History of the presenting problem. The history alone may point to a particular diagnosis if key questions are asked. How old is the patient? This is an important consideration. This man is 75. Bullous pemphigoid typically presents in the elderly. In contrast, dermatitis herpetiformis, DH, chickenpox, pemphigoid gestationis, bullous impetigo, and staphylococcal scalded skin syndrome, SSSS, usually present in children/young adults, and the latter two almost exclusively in children. How long has this problem been present? Infections and reactive conditions will have a short history over hours/days, whereas blisters occurring over several weeks and months, as in this case, are typical of immunobullous disorders and porphyrias. Does it itch? Pruritus is a very useful symptom to elicit and in this case suggests DH, pemphigoid, bullous pemphigoid and pemphigoid gestationis, contact dermatitis, chickenpox, pompholyx or insect bites. Is it painful? Herpes zoster, eczema herpeticum, and cellulitis are painful. Tenderness or burning of the skin occurs in 10 and SSSS. The skin will also be sore if there are widespread erosions, regardless of the cause and especially if secondarily infected. Which drugs? A history of all medications taken in the month prior to the onset of blisters is crucial. Erythema multiforme, 10 and bullous drug eruptions may all be triggered by drugs. Is the patient pregnant? This is clearly not applicable here, but if a pregnant woman had similar symptoms, you should consider pemphigoid gestationis, a specific dermatosis of pregnancy. What was the patient doing before the blisters appeared? This is particularly relevant in acute contact dermatitis. Ask about occupation and hobbies, e.g. a gardener with an itchy rash on his hands may be allergic to a plant. Ask about application of any creams to the affected area. In a patient with itchy blisters on the lower leg, ask about walks in long grass, which suggests bites. Any ulcers in the mouth? Involvement of the mucosal surfaces narrows the differential diagnosis to pemphigus vulgaris, mucous membrane pemphigoid, erythema multiforme, and 10. NB. When you assess a patient with blisters or ulcers of the skin, always ask about soreness or ulceration of the mucous membranes, particularly the mouth, eyes, and genitalia. Patients may be too embarrassed to tell you about genital ulcers and often fail to realize they are linked to their skin problems. Other relevant history. Immunobullous disorders may be associated with other autoimmune diseases and DH with gluten-sensitive enteropathy. Some patients with porphyria cutanea tarda have hepatitis C or alcohol-induced liver disease. Immunosuppressed patients are more susceptible to infections, in which they are more serious. The racial background of the patient may be relevant. In the UK, bullous pemphigoid is more common in white people, whereas pemphigus vulgaris is commoner in Indo-Asians. Blistering disorder examination. General features. Is the patient well or unwell? Is he scratching? Are there any features of dehydration or hypoalbuminemia, which may be a consequence of fluid and protein loss if blistering is extensive? Is there an intravenous drip, which might indicate inability to drink due to severe oral ulceration? Cutaneous examination. The key points to look for are the distribution of the blistering eruption and the morphology of lesions. Distribution. Many blistering disorders show a predilection for certain sites. Mucous membranes. Pemphigus vulgaris. Erythema multiforme, including lips. Toxic epidermal acrolysis. Mucous membrane pemphigoid. Elbows and knees. Dermatitis herpetiforme. Palms and soles. Pompholyx eczema. Erythema multiforme. Lower legs. Bullous insect bites, often clustered. Diabetic bully. Centripetal. Chickenpox. Pemphigoid gestationis, often begins on the abdomen. Photosensitive distribution. Porphyria cutanea tarda, especially backs of hands. Dermatomal. Herpes zoster. Localized and asymmetrical. Herpes simplex, usually clustered. Bullous impetigo. Cellulitis. Acute contact dermatitis. If very localized or asymmetrical, think of an exogenous cause such as infections or acute contact dermatitis. Watch out for the dermatomal distribution of herpes zoster and involvement of the palms and soles in pompholyx. NB. Do not forget to examine the mucous membranes, particularly the mouth. Morphology. Close attention to the appearance of individual lesions may provide the diagnosis. A cluster of small vesicles or punched-out erosions is typical in herpes simplex virus infection. Multiple 2 to 3 mm monomorphic papules, vesicles, and erosions on a background of eczema should make you think of eczema herpeticum. Target-like lesions may be seen in erythema multiforme. Blisters on a background of erythema and edema are typical in herpes zoster, pemphigoid, erythema multiforme, dermatitis herpetiformis, acute contact dermatitis and insect bites. In contrast, Underlying and surrounding inflammation and erythema is minimal in porphyria, pemphigus vulgaris, PV, and diabetic bully. In toxic epidermal necrolysis, TEN, and staphylococcal scalded skin syndrome, SSSS, there is diffuse widespread erythema and the epidermis tends to shear off in sheets rather than form discrete blisters. Are there intact blisters or have they all ruptured to produce erosions? The blisters of bullous pemphigoid are more resilient than those of PV because they are sited deeper, at the dermoepidermal junction rather than within the epidermis. As a result, bullous pemphigoid blisters are often tense with fluid and may be up to several centimeters in size before bursting, whereas PV blisters are easily ruptured to leave erosions. Are there scratch marks, linear erosions, indicating itching, which is particularly common in bullous pemphigoid and dermatitis herpetiformis? NB. Nikolsky's sign. This is positive if a shearing force applied to apparently normal perilesional skin results in epidermal detachment. It is traditionally a sign of PV but may also be positive in TEN and SSSS. Other features. The skin is fragile and breaks with minor trauma in porphyria cutanea tarda, when there may be scarring, hypertrichosis, hyperpigmentation and milia. Scarring is also a feature of mucous membrane pemphigoid, which can lead to blindness. Further discussion. How would you confirm the diagnosis? These will depend on your suspected diagnosis, but most patients with a chronic blistering disease will need a skin biopsy for routine histology and direct immunofluorescence. Be familiar with the immunofluorescence patterns of the main autoimmune blistering diseases, bullous pemphigoid, PV, and dermatitis herpetiformis. How would you manage this patient? One of the general aspects of management is wound care, in particular making sure that non-adherent dressings are used and watching out for signs of infection where the skin is eroded. Widespread erosions are potentially life-threatening, just like burns, and general management in these cases is as outlined for TEN and erythroderma, regardless of diagnosis. Plan for investigation and management. Investigations. In most cases, investigations are required to confirm the diagnosis of a blistering disease. In this case, where bullous pemphigoid is the suspected diagnosis, a skin biopsy would be the key investigation. The choice of investigations will clearly be guided by the clinical findings and suspected diagnoses, but may include the following. Skin swabs for bacterial and viral culture for suspected infections. Do not forget to use viral transport medium. Vesicle fluid for electron microscopy or swab base of vesicle onto glass slide for direct immunofluorescence. For urgent confirmation of suspected viral infections, speak to the laboratory. Blood cultures if infection is suspected. Blood tests. Indirect immunofluorescence may be positive in immunobullous disorders, anti-tissue transglutaminase antibodies if DH suspected, herpes simplex virus and mycoplasma serology in erythema multiforme, and FBC may show eosinophilia in bullous pemphigoid or drug eruptions, and neutrophilia in cellulitis. Porphyrin screen, blood, urine, and stool. Skin biopsy for histology and direct immunofluorescence. Patch tests if allergic contact dermatitis is suspected. NB. Blisters easily rupture to produce erosions, so always consider a blistering disorder if there are skin or mucous membrane erosions. Do not forget to send skin for direct immunofluorescence in these cases. Histology alone is insufficient to clinch the diagnosis of an immunobullous disorder. Management. Management of individual diseases is discussed in Section 2. Be aware that blisters rupture to produce erosions that are potentially life-threatening if they are extensive and widespread, just like burns. If there is widespread erosion of the skin, then general management is as outlined for TEN and erythroderma, regardless of the diagnosis. Cases of TEN and SSSS will need to be admitted. Many of the other possible diagnoses could be investigated as an outpatient, but any patient with extensive blistering or erosion of the skin, regardless of cause, should be admitted. In this case of suspected bullous pemphigoid, a prompt biopsy, ideally on the day of outpatient attendance, and follow-up 1 to 2 weeks later with the results would be appropriate if blistering was not extensive. Treatment could be commenced pending the results if the clinician was confident of the diagnosis. Further discussion. What are the key points that would establish whether the GP's diagnosis of pemphigus vulgaris was correct? The history of itching and blisters in an elderly patient is typical of bullous pemphigoid, the commonest immunobullous disease in the UK. Pemphigus vulgaris does not typically itch and tends to affect younger patients. It also starts with oral ulceration in 70% of cases, so unless the patient has failed to tell his GP about his mouth ulcers, bullous pemphigoid is most likely. To be certain, a skin biopsy for histology and direct immunofluorescence will differentiate between the two. Treatment of immunobullous disorders often involves the use of oral corticosteroids, so be prepared to discuss the potential complications of therapy and any prophylactic steps that should be taken, e.g. prevention of osteoporosis. Azathioprine is a commonly used adjuvant drug, so know its major side effects and be aware of the role of measuring thiopurine methyltransferase levels before starting treatment. It helps with dosing and identifies those at high risk of bone marrow suppression.